All right, today we're diving into a condition that's subtle, deadly, and something every single clinician needs to have on their radar. It's a true master of disguise, and missing it can lead to absolutely catastrophic consequences.
So, let's just start with a number to really set the stakes here. 90%. I mean, think about that. In critically ill patients, this thing can have a mortality rate as high as 90%. No, that's not a typo. It really just hammers home how urgent this is.
So that brings us to the central mystery, right? When your patient is already critically ill, maybe a dozen things are going wrong, how in the world do you spot the one thing that's about to kill them when it looks nothing like what you learned in the textbooks?
Right. We're talking about acute acalculous cholecystitis, or AAC for short. And let me tell you, this is not your standard gallbladder attack. And that right there is precisely what makes it so incredibly sneaky.
Okay, so the big clue is right there in the name, acalculous. It literally means without stones. So this is a serious acute inflammation of the gallbladder that has absolutely nothing to do with a gallstone blocking a duct. It's a totally different beast and a much, much more dangerous one.
And that is exactly why it's such a killer. The source material uses the word fulminant. And if you're not familiar, that's medical speak for something that just explodes onto the scene with incredible speed and severity. This disease does not mess around. It can go from zero to a gangrenous gallbladder, perforation, and a life-threatening infection, often before you even have a chance to figure out what's happening.
Okay, so if it's not gallstones, then what is causing this? And who's the typical person who gets it?
You know, at its core, the problem is this absolutely devastating 1-2 punch. First, you get what's called bile stasis. The gallbladder just, well, it stops emptying like it should. Then, hit number 2, ischemia. The blood flow to the gallbladder wall itself gets compromised. You put those two together, and you've got a perfect storm for injury, inflammation, and eventually, tissue death.
And this perfect storm, it tends to brew in a very specific type of patient. Look, you've got to have a super high index of suspicion in anyone who is critically ill. We're talking about your ICU patients, people with sepsis, major trauma, or severe burns. Anyone who's been fasting for a while, is on TPN, or just had a big surgery, especially something like a cardiac bypass. They're all at risk. Oh, and here's something interesting. In these critically ill folks, it's overwhelmingly men who get this.
All right, now for what is maybe the hardest part of all of this, finding the evidence. This is where AAC really earns its reputation as a master of disguise, because it just doesn't play by the usual rules.
Yeah, this just completely flips the script on everything you learned. That classic textbook right upper quadrant pain, gone. It's absent in up to 75% of these cases. A positive Murphy sign, you know, that little test we all do, often absent, or it's totally unreliable, especially in a sedated patient in the ICU. The takeaway here is so important. If you are sitting around waiting for the classic signs of gallbladder disease to show up, you are going to miss this diagnosis. Period.
So instead of that localized pain, the real clues are kind of buried in the patient's overall clinical picture and, crucially, in their lab work. Your alarm bells should be ringing any time you see an unexplained fever, sepsis that's getting worse without a clear source, or a white blood cell count that's climbing. A little bump in their amylase or some new weird changes in their liver function tests, those are also major red flags.
Okay, so let's say you've got your suspicion. You've got a high-risk patient, you've seen some of these subtle clues. Now you have to prove it. And for that, imaging is absolutely key.
So the investigation usually follows this 2-step path. You start right there at the bedside with an ultrasound. It's fast, it's easy, and you're looking for some pretty specific things, like a thickened gallbladder wall or some fluid hanging around it. But, from there, you often have to step it up to a CT scan, which is just going to give you a much clearer, more detailed picture of what's going on.
Now, this table is great because it really breaks down your choices and the pros and cons of each. Ultrasound, it's fast, but man, it has a high false negative rate. A HIDA scan, which checks the duct function, is super sensitive, but it can give you a false positive, and even worse, it can delay treatment. And that's really why the sources point to the CT scan as often being your best bet overall. It's just superior for spotting complications, and this is critical for ruling out other dangerous things happening in the abdomen. All right, you've unmasked the killer. Now it's time to act. And I mean right now. This is where decisive, life-saving action comes in. There's absolutely no time to waste.
Okay, so management starts immediately, even while you're still getting things lined up for the main event. First,
Get those blood cultures. Second, start powerful, broad-spectrum IV antibiotics. And third, make sure that patient is getting fluids and whatever they need for blood pressure support. The name of the game here is stabilize, stabilize, stabilize. This quote from the source material, I mean, it really just says it all, doesn't it? The key words are early and rapid. This is a disease that moves at lightning speed, and any delay, any hesitation can be fatal. There is simply no room to wait and see with this one.
And this brings us to the central decision point. It's really a fork in the road. For your critically ill, unstable patient, the one who would never survive a big surgery, the answer is what's called a percutaneous cholecystostomy. Basically, an interventional radiologist uses imaging to guide a tube right into the gallbladder to drain it and relieve the pressure. But for the patient who is stable enough, the goal is removal, a cholecystectomy. That's the definitive cure.
Okay, let's bring this all home with a classic clinical case. You've got a high-risk patient, right? A guy who just had heart surgery. You've got those subtle clues, the unexplained fever, the rising white count, the worsening shock. And boom, you have the imaging finding, a thickened gallbladder wall. This, right here, is the textbook, or maybe I should say the non-textbook presentation of AAC.
And let's just end by circling back to the stakes, because they are incredibly high. Just look at this stark difference. For a patient who gets this out in the community, the mortality rate is actually pretty low. But for the critically ill patient, the one we've been laser focused on this whole time, it just skyrockets. The outcome depends entirely on their underlying condition, and I cannot stress this enough, on how quickly you make the diagnosis and you act on it.
So look, this isn't just some academic exercise. This is a call to action. The next time you're on the wards, the next time you see a critically ill patient with an unexplained sepsis or a fever that just won't break, ask the question. Think about the gallbladder. Keeping this diagnosis on your radar can, and I mean this without any exaggeration at all, save a life. So who in your hospital needs you to be thinking about AC today?